Good morning. My topic is about visual field and eye opener to neurophthalmic presentation. Eye is considered as insight to the central nervous system via the efferent pathway by the optic nerve, optic chiasma, optic tract, optic radiation, and to the occipital lobe. Varied ocular signs and symptoms presenting the OPDE expected to have a visual field defect relation to the anatomical site of location. Aim of my study is to explore about the nature of the neurophthalmic presentations, etiologic causes for the referral, and association with the pattern of visual field defects. Our study is a retrospective review of the electronic medical record conducted in an eye care center in October 2022 to May 2023. Study participants include 242 patients referred from a single national neurology center in the same locality. Study parameters include clinical history, symptoms, visual acuity, ocular motility, pupillary reaction, salient features of anterior and posterior segment finding, visual field defect, and color vision. Coming to the result, majority of the population found to have female predominance with the age group peaking in 11 to 20 years and 41 to 15 years. And majority of patients were asymptomatic. And among the symptoms, division is followed by headache, diplopia, eye pain, and proptosis. And ocular findings elicited dyschedema and temporal pallor about 9 to 10%, and others like RAPD, nystagmus, abduction limitation around 4 to 5%. Coming to the diagnosis, 60% of the referred cases were intracranial space occupied lesion, followed by inflammatory causes, demyelination disorders, seizure disorders, idiopathic intracranial hypertension, vascular, and others. Coming to the subetiology classification, majority were arthropathies followed by vasculitis, including Uppler giant cell arthritis, and in seizure disorders, majority were epilepsy, about 72%. Optic neuropathy and multiple sclerosis comprise about 60% in demyelinating disorder, and in vascular etiology, arteriovenous malformation and followed by corticovenous thrombosis. Only 9% of the patient referred as carotico-cavernous fistula. To summarize, major referrals were intracranial space occupying lesions, among them pituitary adenoma, followed by meningioma, glioma, and craniopharyngioma. Only in arthropathies, we found have non-specific visual field defects. In optic neuropathy, a small proportion had a central and centrocecal scotomas. In intracranial space occupying lesion, pituitary adenoma and craniopharyngioma found to have a bitemporal hemianopia, as the site of lesion is in the optic chiasma. And in meningioma, we got an incongruous hemianopia, and glioma, we got a congruent hemianopia. Coming to discussion, on literature search, a study by Sarang et al. Found have matched with our study in gender, age, group, and the tumor incidence. And we got a smaller study by Nassif et al. And Deshmukh et al. Have pituitary adenoma as the main tumor incidence. We found have the visual field bitemporal hemianopia. These slides show the vulnerable site of the lesion produces bitemporal hemianopia. Limitation of my study is a retrospective nature and data entry lacking in the specific correlation of the extent of visual field defect with the tumor size, location on neuroimaging, and histopathology reprint couldn't be done, and poor referrals for follow-up. Conclusion: ophthalmologist is very often the first physician to encounter the patient with neurophthalmic manifestation. A keen evaluation including the visual field charting and correlating of visual field pattern with clinical presentation help in early recognition of life-threatening tumors. These are my reference. Thank you.
So here the title should be clinical profile of patients presenting to a tertiary eye care center in neuro-ophthalmology, not visual fields and eye opener, because neither pre-op or do you have a first visual fields was done for all who presented?
Yes.
Yeah, but then you didn't describe the pattern type.
I think you took the neuro-ophthalmology visual field defects from the EMR, right? All these cases where visual field was done, non-glaucoma, I mean, where this was
Referred from
found to be referred and other. Uh,
Yeah. So visual fields, since you have written visual fields as an eye opener, you should what you're supposed to present is like how visual field has helped you to diagnose it's a craniopharyngioma or it's this thing. But here you have just described the profile and then you of the patients presenting at your center. This many were craniopharyngioma, this many were pituitary adenoma, like that. So the title itself is misleading.
Subetiology like rheumatoid arthritis on HCQ treatment. We
how did you? I have no idea. I saw that. I didn't want to ask.
How is that
Yes.
How was
neuroophthalm?
that neuroophthalmology thing found? Because many of the HCQ patients have their own field effects and other this thing. So,
any field effect.
so what you are telling is they came for HCQ screening and then found that there was associated. That is 19 cases, I think. Quite high, no? That is 19 cases in of HCQ screening cases. Just show that. Back. 19 cases. The 19 cases of visual neurophthalmic field defect were evaluated for HCQ screening probably. It is quite high. It's quite high. But we don't see neuropthal defects in many of these.
What field you have not mentioned? 30-2, 24-2.
Was it same in all?
Was
Or
it
it
same
was
in all?
some in
Yeah.
some were full field, some were 30-2 like that. And you said 192 patients had no symptoms. No, 192.
Majority patient were all they referred for visual field.
Oh. There are a lot of lacuna in the sense, what is that, bias or because some may be referred by neurologists for ophthalmic evaluation. That is another thing. So you know that something is happening. They just want to find there is a field effect, like tumors and all. So this is actually a mix-up of all these things. That is the last slide you show. Conclusion. Not pure ophthalmic. It is the last slide. Your conclusions says ophthalmologists are often the first physician to encounter patients in neurophthalmic manifestation. How can you conclude that? Because many of the cases are sent by neurologists. All of you, when you write the conclusion, what you conclude from that study you have to include. Not just in this study, probably you can say the highest percentage is due to craniopharyngioma or whatever neurophthal cases, something like that. That is acceptable. So this is it doesn't. It is not the conclusion from this study. I will show in next presentations also. These are small things that you should take care. And always ask the same question: what is new? What is new? What is new? So these are few things from my part.
Here, the take home message from your study is that pituitary adenoma were the maximum presented and referred to your institute and as similar to other studies. That was only take home.
In this,
In this.
what you could have done is cases which came to the ophthalmologist and you found something, what percentage is that? That has weightage. Some cases we will just, patient may be complaining something, then you did the bitemporal or hemianopia is there. That small percentage, that can be, if that value is there, you could have told the first line. Okay. Thank you. Nice presentation. So, certificate.